All right, here we go. Excuse me. All right. Oh, I know what we forgot. That's why it looks so dim. Forgot to turn some of the lights on. Can't have that now, can we? There we go. That's looking a little bit better. Welcome in, Navigator Nation. Appreciate everybody stopping by on this Wednesday evening or afternoon, depending on where you're at. My name is Mike Hess. I run the group COPD Navigator on Facebook, and I also have the COPD Navigator YouTube page, and we've got a website, and we got all kinds of stuff. And about every 2 weeks or so, we get together and we talk about what's going on in the world of COPD. For those of you who may be new to the program, I have been a respiratory therapist for going on 15 years now, active in the world of COPD over the last several years, trying to raise awareness and improve the education of our folks with COPD, their caregivers and loved ones, their friends, their family, and the healthcare community. We do this program as I said, about every 2 weeks, where we have a couple of hot news items from the world of COPD. We have a lesson plan for the day. In this case, this episode is going to be all about various inhaler techniques and how to make sure that you're using the right technique for your device. And then, of course, we can get your questions answered live. Through my years of experience and research and all that stuff, happy to share whatever wisdom I can, whether it's on one of today's topics, whether it's on one of the news issues of the day, or whether it's just something else that's on your mind. So, as we try to recover here, I've been doing a little bit of other experimentation with some other stuff. Other projects we've got going on, so we did have a couple of cables to reconnect there, but we are going to go ahead and get started. First off, we'll take a quick look through our supposedly unified chat box. That's not showing up anything there. Let's see who we've got joining us today. Hope everybody's having a great Wednesday. Let's see. Welcome in to everybody who's viewing us through various parts on Facebook, or if you're catching us on good old YouTube, appreciate everybody stopping by. So without further ado, we are going to get on to our first topic of the day, which is kind of an interesting one. A study just came out of Canada, I believe it is. Originally came out of Canada and did actually get, this is reinforcing a study that came out close to 10 years ago now through the Department of Veterans Affairs, actually here in the U.S. That tells us that COPD is a more prevalent comorbid condition amongst those living with HIV positive status than it is in the general community. In addition, yes, this study did come from Toronto, Ontario, and the study came about because they were trying to get a better grasp on population health in the HIV positive population. That was despite the fact that we've been having HIV patients, people living with HIV for a lot longer than we used to. Still didn't know a lot about some of the long-term effects on their health. And so what they did, this group looked at health administrative databases from the province of Ontario for approximately 20 years and found a little over 1,800 HIV positive patients and 1.1 million HIV negative patients who had COPD. And they found that they actually had, you actually were more likely to have COPD if you were HIV positive, and it was also found a little bit earlier. Now, interestingly, they figure this is largely because smoking rates are still much higher amongst those with HIV positive status than they are in the general population. We've seen over the last several decades now a fairly regular decline in smoking rates in the general population. That does not seem to be the case with those amongst those with HIV status. Now, why that is another interesting question. There's a lot of thought that there's still significant stigma attached to HIV positive status. There's still a significant stigma amongst those who are most likely to be HIV positive. The LGBTQ community, intravenous drug dependent folks, all those kind of groups. So they use less healthy coping mechanisms like tobacco in order to deal with those stressors. So when you have a population that is more likely to smoke, you have a population that is more likely to have COPD. So a lot of that is pretty straightforward and does seem to make logical sense. But in order to start addressing problems, we have to first identify them. So this study out of Toronto is the first step to identifying that issue. Interestingly enough, let's see. They did see a little bit of decline, but not a significant amount. And they did. I'm trying to find where exactly it was. I remember reading in the summary that they actually were able to find it somewhat younger than in the general population for reasons that are a little bit unclear, but likely because those folks with HIV positive status are probably going to have a little bit more frequent contact with the healthcare system as they're managing that part of their health. And so then maybe a little bit more sensitive to changes in their respiratory condition. In the general population, actually I had a great conversation about this with some of our respiratory therapists in training over at Kalamazoo Valley Community College, my alma mater, for my respiratory associate's degree. Had a great conversation about how humans are very adaptable species. We'll start taking the elevator rather than taking the stairs. We'll chalk things up to being out of shape or getting older, all that kind of stuff, rather than looking at the possibility of a respiratory condition. So it's possible that those folks who are living with other conditions are, again, a little bit more tied into that, a little bit more sensitive to changes in their respiratory condition. So further research will give us a little bit more of a clue on that, I'm sure. On the topic of smoking cessation, that is actually our second news item. Over across the pond relative to where I'm at in Michigan, they have a ongoing or a periodic anti-smoking intervention called everybreath.tv. The Every Breath initiative is actually a multimedia kind of deal. There's radio spots, there's television spots, there's magazine articles, magazine ads, all that sort of thing, all aimed at connecting people with resources to help them quit smoking. And to try to reduce the risk specifically of COPD. We know that a lot of these anti-smoking initiatives tend to focus on the risks with, for example, lung cancer and that sort of thing. But we also know that a huge issue in the smoking community is COPD. So this particular intervention, you can see I got the website pulled up here, and you can see a clip of that on the screen in front of you there. Connects folks over in the UK. This is in a particular part of the UK called, well, it doesn't matter, but it's over in the UK. Talks about finding your local stop smoking service, order free quitting tools, and is really aimed at trying to get people to quit smoking and have a little bit healthier lifestyle to reduce their risk of COPD. You can see they have. Oh, that's not going to be good. I bet that sounded fantastic as I dropped the tablet right into the microphone. But you can see they've got some television advertisements. They've got connections with the British Lung Foundation. They've got a lot of stuff. They've got Facebook, Twitter. Even if you're not in the UK, I would probably advise checking them out because, while the services are specific to a particular location in the UK, the theories and the tools and all that stuff behind tobacco cessation are pretty universal. I mean, of course, there's going to be some cultural differences between UK and US and all that sort of thing, but the support and the logic behind this stuff, there's not a big difference between UK lungs and US lungs. So if you're having trouble quitting smoking and you don't have other resources to connect with, check these out and see if they can be of help. Next up is, of course, something that is on everybody's mind. Our new old friend, SARS-2 coronavirus, the novel coronavirus, the illness that comes from it, COVID-19 coronavirus disease from 2019. We are still seeing increasing numbers in the U.S. and in some parts of the world. In somewhat good news, the prevalence is decreasing a bit where it started in China, mainland China. That gives us some hope for containment still, although, and again, not to get too political, there's been a lot of controversy about how the United States health infrastructure has been handling the potential for quarantines and all that kind of stuff. I have been continuing to monitor the situation. I will say that I still will believe that as from a strictly clinical point of view, a lot of what we're seeing in the media is still a little bit hyped up, a little bit over the top. I was watching I know many of my clinician friends may be familiar with a gentleman by the name of Z-Dog MD, Dr. Zubin Damania from out west. He's in California now, isn't located in Vegas for a long time. He is a hospitalist / internal medicine specialist, and he has been also following this very closely. He is a large-scale health advocate for trying to get a lot more sanity into healthcare in general, a lot more humanity back into healthcare. He had a great presentation this morning. He does these things, look him up, Z-Dog MD, where he actually talked with his father, who is a 80 years old, has some COPD. As a matter of fact, he mentioned on the show this morning about what his thoughts are from a new to America perspective. And a lot of the issue there was worried about retirement, worrying about the impact that this has had on the stock market. And I think that there's a certain lesson to be learned there, where a lot of the issues are going to be more outside the clinical realm. We're going to have operational things. We are going to have some healthcare, some strain on the healthcare system. I think we're going to be seeing some of those issues pop up. What we see from the clinical side of things, I was looking the COPD Foundation, as they often are, right on top of a lot of these issues. If you also follow COPD 360 Social, which is the foundation social media outlet, you can see there's been some great work from Jamie Sullivan, who is a public health official and does great work for the foundation for the clinical side of things. They have a lot of updates there talking about, for example, they have a great question and answer set up, like, for example, can I catch COVID-19 from packages like in the mail or grocery bags, stuff like that? Yes, but it is very unlikely. We don't know exactly how long the virus lives on surfaces, but it is very unlikely. And the quote there is, it may be possible that a person can get COVID-19 by touching a surface or an object that has the virus on it and then touching their own mouth, nose, or eyes, but this is not thought to be the main way the virus spreads. In general, because of poor survivability of coronaviruses in general, remember, this is not the only coronavirus out there, simply a unique, novel one that was found this year. there is very likely low risk of spread from food products, packaging shipped over a period of days or weeks at ambient, refrigerated, or frozen temperature. So you're probably not going to get it from packages. It is arguably more likely than packages, but less likely in general that countertops, things like that, you're not going to get that. The biggest threat remains coming into contact with a carrier, identifying who those carriers are. We had, originally this, of course, spread from one spot in China and has gone into community spread mode a little bit. It's really difficult still at this point to figure out exactly what the threat is. There's going whatever media outlet you see, you're going to see a lot of numbers get thrown around. You're going to see words like case fatality rate. You're going to see numerator and denominator, going back to fractions, because those are things we use in public health to try to figure out what the risk is for folks. The best data that we have tells us that in general, the general population, 80% of the cases are relatively mild. Another 15% are more severe, or you might actually have some healthcare encounters. You might get admitted, stuff like that. Excuse me, about 5% are very severe. And those are the folks who are going on ventilators, going on other respiratory support in the intensive care unit. Now, that said, that's the general population. Most of the people I'm probably talking to now already have some kind of impairment in their immune system. You get that from pretty much any chronic condition, but particularly one that affects your respiratory system, like COPD. So you are likely to be at higher risk, and you need to take some precautions. You need your caregivers, your family circle, your friends also should be taking precautions. Now, the relative good news is that while this is not exactly like the flu, a lot of the precautions that you should be taking are very similar to ones that you should already have been taking because of the flu. Hand washing remains one of the biggest weapons that we have. This virus has an envelope around it that is very susceptible to disruption from soap. It's also susceptible, less so than with soap, but also hand sanitizer. So keeping your hands clean, keeping your hands away from your face, also a big issue. You know, of course, if you're, for example, at your doctor's office and you touch the counter when you're signing in and you immediately go to wipe your face, that is basically conveying, it's almost like eating. It's conveying, it could potentially convey that right into a point of access for your immune system, or to be infected. Try not to touch your face. That's kind of an issue where we've seen a lot with masks. People asking about, should I wear a mask? Should I not wear a mask? When you are wearing a mask, it can convey kind of a false sense of security and, well, I can still touch whatever I want. I'm going to be fine. It's not a big deal. Masks are only effective if they're worn properly, if they're put on and removed properly, and if you're still not touching your face, and if you're still washing your hands and doing all the other things. Can they add an extra layer of protection? It's possible, but again, you have to be using the special N95 healthcare masks. You have to be putting them on, taking them off in the right way. You know, we actually have training for this in the healthcare world, how to put them on properly, how to take them off properly. So when we see all these people going out and buying up all these masks and first of all causing shortages of N95 masks, maybe good intentions, but also considering that there are other things that healthcare will need N95 masks for, that can be a concern. We know that we see a lot of people coming in with the standard like the tissue kind of masks, surgical masks, they're usually called. Those may help prevent you from spreading it if you're already sick, because we know that when you cough in a mask, that usually keeps it in, but it's not really going to do much for stuff coming in. They're not sealed very well. I even have trouble, people like me, this is one of the the margins for where an N95 mask would sit, and because I have hair here, it prevents the mask from sealing properly. So I would have to wear a special kind. I would either have to shave my beard or wear a special kind of air protection called a capper or a papper, where it's actually more of a hood. Those are the kind of things that the logistical issues are where we're really seeing a lot of the strain right now, and where we have a lot of concern. So you see on the screen here some other advice that has come from CDC, World Health Organization, which is currently my go-to for a lot of information. Again, not to get too political or anything like that, but there's been a lot of concern that some of the information coming out of the domestic CDC may be biased one way or another, maybe pushing things or looking at certain things to minimize, to distract, to whatever. World Health Organization doesn't really have a lot of those concerns, and they're also looking at things from a more global perspective. They are the World Health Organization, so they have resources that maybe aren't as that are maybe a little bit more broader than even our CDC, which historically has been fantastic. But WHO has boots on the ground at the origin of this particular pandemic, which I believe they're now calling it a pandemic, which is not necessarily as scary as it sounds. A lot of people think pandemic is world-ending, apocalyptic kind of stuff. Pandemic simply means that you have outbreaks in at least 3 different parts of the world, which we're seeing now. It's more of a measure of infectious risk rather than severity. So they've got people, back in Wuhan. They've got people in Italy, which is another huge, they're having a huge outbreak there. They've got people here in the U.S. They've got people all over literally the world, as is their mandate. And so they have a little bit broader view. So they're kind of my go-to right now, looking at a lot of that stuff. The COPD Foundation, because they're specific to the COPD population. And that's where these recommendations that you see on the screen right here now are. Again, we talk wash your hands, wash your hands, wash your hands. Don't touch your face, especially without washing your hands first. Keep your distance. Social distancing is probably another word that you're going to hear a lot. And we've already seen a couple of festivals get canceled. The South by Southwest Music Festival down in, I believe, Texas, has been canceled. We've seen Coachella Music Festival has been postponed. The American College of Cardiologists has postponed one of their main annual conference. We're seeing a lot of colleges starting to go virtual, canceling in-person lectures and things like that. I guess it's an abundance of caution, abundance of safety. If you are at high risk, or if you have close family members or friends who are at high risk, these are all very eminently logical. People in good health, I will leave that decision to others. Stay at home if you're sick. Stay at home if you're at high risk, because, again, a lot of this stuff is kind of common sense. The way I've been looking at it, and I know this is easy for me to say as I'm relatively healthy and I don't have sick family members and all that stuff, is it's kind of like being struck by lightning. If you get struck by lightning, you're going to have a bad day. It's going to be a bad outcome for you. And again, a lot of my friends in the COPD community, if you get this particular coronavirus, SARS-2, NOV-19, whatever we want to call it, COVID-19, if you get it, it's not going to go well. I'm not going to sugarcoat that. But we don't yet know exactly what the risk is for getting it, just like we don't always know walking outside if we're going to get struck by lightning. We still take steps to mitigate that. We discourage people from playing golf in lightning storms. We discourage unsafe behavior, just like we're going to discourage unsafe behavior here, because and in this case, this also has the knock-on effect of protecting you from other stuff like the flu, which may not be as severe depending on what numbers you want to look at, but is flying around a lot more. We encourage people to get their flu shot every year. So this is it's as a public health advocate, as a COPD advocate, it is a very fine line because I don't want to minimize the risks, particularly again in the group that I'm generally talking to. But I also don't want people to go into panic mode because, as I've told a couple of people this week, panic is going to be a lot worse for us. Panic is going to stress the system. Panic is going to cause shortages. Panic is going to cause a lot of effects that aren't necessarily needed. So follow logic, follow your safety protocols, follow this stuff. Speaking of logic, there's been a lot of talk about using the Vulcan salute as instead of a handshake, which as a lifelong Trekkie, as many of you can attest, I am fully on board with, and has the additional effect of also honoring to a degree Leonard Nimoy, who passed away from COPD complications a couple of years ago now. This is a great way to greet your family members without making contact, without worrying about how clean their hands are, how clean your hands are. Elbow bumps, I've seen it's another thing. You do that instead of a high five or a handshake, anything like that. Again, we're looking at reducing the risk because this is not something you want to get. It's also not something that you necessarily need to have nightmares about. As I touch my face, that's great. I'm setting a real good example for everybody out there. So let's so that's our biggest kind of news breaks for the day here. Let's see. What do we have going on? Let's see if we can find some of the comments here. I'm going to scroll back a little bit and say hello to Linda joining us from here in Michigan. Oh, by the way, I also wanted to point out, if you are concerned, if you are nervous, that is absolutely appropriate. I understand the feeling. This morning I woke up first thing, as many in our generation do now. First thing I did was check my phone. First news item that popped up was Michigan has our first 2 suspected cases of coronavirus. And I immediately felt, as many people do, that, uh-oh, here we go. I understand that fear. I understand that concern. I urge everybody to try and manage it as best as you can. And again, we talked a couple weeks ago, a couple episodes ago, about mental health concerns. If you're feeling upset, if you're feeling panicky, if you're feeling all these things, please talk to somebody. Don't hesitate to get advice. Don't hesitate to seek out support, all that sort of thing. It is perfectly normal to be concerned. It's perfectly rational to be concerned. We just can't let that guide everything. So also want to say hello to Sharon joining us from North Carolina. Sharon, another one of our folks who has some immune compromise and is at relatively high risk. And Sharon is also throwing herself out there day in and day out as another major advocate for COPD or people living with COPD. Recently joined myself and several other folks on the U.S. COPD Coalition. So congratulations to Sharon for picking up that mantle, even with as much as she's got going on. Really appreciate her wisdom. Also in our group, COPD Navigator here on Facebook. Linda Hendricks, hello to you. Pam, Pam Plosh, a huge advocate for people living with COPD, living with it herself, and some other issues going on. Great advocate and great conversation starter in our group. Pam, welcome in. Linda, hard not to touch your face. Noses itch from oxygen. Absolutely. When I give this advice, I want it to be clear that I'm not just, I know it's all easy for me to say. I don't have to walk this path. I don't have to throw all that stuff out there. And I don't mean to minimize the challenges that are out there, because I know intellectually, at least, that they are significant. If you are able, I know this is not really a portable thing, but if you're able to keep your nose hydrated, please do that. And again, this is avoid touching your face, particularly when you might be conveying something. If you touch a counter, wash your hands, then you are lower risk for touching your face. If you're washing your hands thoroughly, 20-second rule, all that kind of thing, then you are, again, lowering your risk. Unfortunately, life is not risk-free. And again, I know that sounds on its face kind of cavalier, but we all have to do what we can to minimize our risk for a lot of this stuff. It's not going to be easy. It's not going to be fun. It's not going to be foolproof, but it is what we can do. MSU also, yes, they were one of the ones that went to online classes. My daughter was talking about, I know you're not picking on me, Linda. I appreciate that. And it is a thing. Like I said, as soon as I touch my, as soon as I said it, I touched my face. One of my daughter's friends had, she was doing Model UN this week at MSU, and that's been canceled. So her senior year, now she can't do this thing that she's put a lot of work into, and so that's why there's a big part of me that says we don't necessarily want to overreact. We don't want to minimize, but we also don't want to overreact. It's really difficult to find that middle way, as my Buddhist friends would say. Very hard to walk that fine line. So, but we are going to all get through this together, and we are going to figure out how to make it work. So, with all that said, we're going to move on to our topic of the week, which is checking your technique. Now, again, I mentioned earlier, we had a great talk today over at KVCC talking to the next generation of respiratory therapists. And one of the things I pointed out to them was we have had metered dose inhalers, our old friends, MDIs, the puffers, all that kind of stuff. We're going to see if we can get that. There we go. We have had these things since the 1950s. I want to say 1953. I can't say that 100% sure. I know it was in the 50s though. The design, the shape, this is a demonstration inhaler. So this whole thing, this has not, some of the cosmetics have changed, some of the propellants have changed. We've seen all that kind of stuff. The device itself has not changed in a significant way other than the big change in propellants a few years back. Since the 1950s. Now, we look back at the 1950s and actually used an example. There was a study that went back to the 1970s, and we see the changes in technology and the changes in virtually everything in society over the last now 40 years. And what we don't see is a change in inhaler error rates. We have seen some oscillations, we've seen some ups and downs, some improvements, but it always seems to go back to, mathematicians would call it reverting to the mean. We always seem to be stuck at only about 25% of people who are using these things are using them correctly. And that sounds kind of dismal, and it kind of is, because we also look at over the last 40 years, mortality rates haven't really changed much in COPD. Quality of life impairments haven't really changed. Disability rates, all this stuff hasn't really changed. And a lot of times we consider it to be, we look at it, well, we haven't had new medication classes in a while. We haven't had new molecules for a while. Research hasn't been a thing. We look at a lot of issues that are, well, why haven't we affected these healthcare indicators? To me, a lot of it comes back to the fact that we aren't using the tools that we have properly. We aren't teaching properly. We aren't considering these things properly. And that's on us on the clinical side. And we can get into a whole conversation about healthcare design and healthcare delivery. And shameless plug here, if you're interested in that, you can go to wherever you look for podcasts and look for a show called Potato Cast, because I have started doing a podcast about these kind of issues. The first episode is about pharmacy benefit managers and why we have to do prior auths and how that affects care. The next episode we're coming is going to be talking about asking the right questions and worrying about confounding factors in research. So try to take some of these issues and translate it out there, more of an audio format. So again, Potato Cast, wherever the finer podcasts are sold, or if you go to Pinecast, you can search for Potato Cast. But we'll get to all that stuff later. We'll also have some links on COPD Navigator. We'll get all that stuff up anyway. But so a big issue here is, if we look at, this was a study that came out a couple years ago from the COPD Foundation, our good friends at COPD Foundation, who studied a variety of healthcare providers. You can look here. On the top row here are pulmonologists. I don't know why they get a D instead of an L, but pulmonologists, then primary care providers, then non-physician providers. These are NPs, PAs, everybody else. And then down at the bottom is all kind of the conglomeration of everybody. This particular question was, when you consider prescribing a maintenance medication for someone new to a COPD diagnosis. So this is somebody that obviously you've done your spirometry on, right? Because everybody's getting spirometry. They're stable. This is not somebody in the middle of a flare, anything like that. Which is more important to consider? Do you consider the medication or do you consider the device? And overall, 9 out of 10 of every provider said that they consider the medication to be more important. Now, there's a certain argument to be made there because, yes, it is the molecule that is actually doing the thing inside the body that is giving you the bronchodilation or the reducing inflammation or whatever it is. But is it more important? If you can't get the molecule, is it going to do you any good? And so the delivery device, to me, is just as important. Now, especially when you stop to consider, this is a chart that comes from, maybe I'll try on this side here. This is a chart that comes from our good friends at the Asthma and Allergy Network, in conjunction with a couple other groups that are out there. These are all the inhalers that are on the market. And actually this poster is, this is last year's poster and is about 6 to 8 months out of date now. There's at least one new one that's not represented here. There are a couple of generics that are not on here now. There are all these things coming onto the market all the time. And each one of these has a somewhat different technique, whether it's opening the thing up, priming it, the inhalation flow, all that kind of stuff. And this doesn't even consider nebulizers. You know, nebulizers have their own quirks about cleaning and a replacement of parts and things like that. So we want to make sure that we're able to give people the tools that they need, but also that they're able to use the tools. Now, in good news, this was also part of that study that was done by the COPD Foundation. And people are actually, while they may not be putting it above the medication or above the molecule, they are considering that these devices are important. You can see here between blue and red, which is highly important, somewhat important, most of each category, we're looking in that 80 to 90 range of considering it to be somewhat important. Now, it stands to reason that a lot of these things, you know, a lot of these providers, a lot of these clinicians, if it's important, then they're going to find time to do it. And again, this is where some of the healthcare delivery aspects come in, you know, with your 15-minute primary care visit, or trying to teach somebody how to use an inhaler in the emergency department when they're already stressed and tired and hungry and want to go home and sick and not paying attention, or they're getting ready to go home after their admission. The discharge planner comes in and you're sick and you're tired and you're hungry and you want to go home and you got to coordinate the ride and you got everybody else coming in to teach you all this stuff. Or you're getting your inhaler from the pharmacy, except it's a mail order pharmacy, or you're in the drive-through because you've got 8 other things to do. Or you're at a line and there's 8 other people behind you in line. I don't know why I'm fixated on 8 all of a sudden, but all of these issues make it very difficult to teach and very difficult to learn. So how do you know you're doing the right thing? Well, first of all, when we look at these inhalers, we've got the 2 main kind of inhalers. We've got these kind of devices. This particular device is called an Ellipta. It's manufactured by GlaxoSmithKline, GSK. They have a range of medications in it. I am not sponsored or anything like that. This is perfectly fine a tool for the right person, just like every other tool I'm about to show you is perfectly fine. These are all just for demonstration purposes. I am a firm believer in the right tool for the right person, and I don't care who pays me otherwise. I will always stick to that. So this particular one is called the Ellipta. This is a multi-dose dry powder inhaler. This is the part where it gets a little bit tricky to do online, but we're going to try it out. This one you open up like so, and then hopefully I can get this close enough to the camera here. You can maybe see, I don't know how the focus is going to work here, but you can kind of see, you may be able to see that there is kind of a mesh screen in there. What that mesh screen does is, if anybody ever played with a cap gun when they were a kid, they know that they used to come on rolls. They, and a little thing of gunpowder, and you pull the trigger, and boom, and cowboys and all that stuff. Basically the same concept in one of these. When you pop that open, you peel the top layer of tape off, and there's a little cake of powder, medication powder, that sits in there. And when you inhale on this thing, the powder comes up past that screen, gets broken up into basically a dry mist, and that goes into your lungs. But we also know that a lot of people with lung problems aren't able to generate enough flow in order to actually draw that powder out, to break it up into the particles, to get it past that screen, and to get it down into your lungs. And on top of that, I unfortunately have misplaced, it seems, some of my other demo dry powder inhalers. So that's a bummer. But we'll pull back up on the, we'll pull up the poster again here real quick. You can see, for example, if we're looking at, I wish I could get my arrow on the screen here, but we look particularly in the yellow row there, that where it says muscarinic, antagonist, anticholinergics. The second, third, fourth inhalers on there are all different dry powder inhalers. They all have different characteristics. The first one there, the Neohaler, that has a single dose. Many people might be familiar with the Spiriva Handyhaler. Similar concept. You get a blister pack of pills, you pop one out, you put it in the device, you crack it, you do all this stuff, and then you inhale it. Then you see the Ellipta, then you see the Handyhaler again. Up a couple rows, we start seeing the Discus, which is a little bit old school. If you've ever had Advair, you see the Discus. Going back to the yellow, we can still have that on the screen here. We've got the 2 doors of Press Air. So all these things have different internal resistances, different formats, different clicks, different all that stuff. And you've got to be able to figure out how your person is doing in order to get the medication out. And that's where this kind of device comes in. This is something that, and again, I don't work for Clement Clark, the manufacturer of this device, but I am firmly a believer, even though I don't get paid for it, I will still tell you that every clinical office that deals with somebody with respiratory conditions should have one of these things. It's called an in-check dial. Basically what it is it's a meter that can sense your inspiratory flow, how much flow you're generating to get that powder out. And what makes it a dial is that, you should be able to see it on here. There we go. As I rotate it, you can see the little orifice in there getting larger and smaller as we move it around there. Because this device is able to simulate the resistance of the different inhalers that are on the market. And using this, we're able to set it to a particular range based on your type of inhaler, and figure out if you're able to generate enough inspiratory flow. So, for example, our friend the Ellipta here is classified as a medium-low device. And so I will get out my handy dandy disposable one-way valves here. Because again, infection control, whether we have corona or not, is a big deal. We reset the meter like that. This is no batteries, no nothing. This is virtually foolproof. I say virtually because the minute I say that it is foolproof, I will break it. That's just the way life goes. We will set it to the appropriate resistance, and we will inhale. Like so. We want to make sure that you're doing a nice sharp inhale, because you want to hit that, what we call the peak inspiratory flow, very fast, so that you're breaking up that powder instantly and capturing it into the flow down into your lungs. Now, we see on this particular resistance, I, having relatively healthy lungs, am able to generate, we've got our little indicator there, and I am able to generate about 95 liters per minute of airflow. Now, we know that studies tell us that we can be fairly confident. I will avoid saying we know, but if you have a flow on the appropriate resistance of 60 liters per minute or more, you can be reasonably sure that you're getting your medication out. We know that in most cases, if your flow is below 30, you have very little chance of getting the medication out. And if it's between 30 and 60, that's a little bit more of a gray area. That's why, we have kind of that labeling on here where it's green up to a certain point. We can go by symptom burden and changes and all that stuff to actually figure out whether we're actually, if somebody's actually getting the stuff out or not. Now, this is always an eye-opener. Like I said, I had that set to medium low. And I'll do it again just because I want to try to be as clear as possible. I'm doing a maximal inhalation here. And again, I get up to that 95 to 100 liters per minute. If I rotate this all the way down to maximum resistance and do that same maneuver, it is a lot more challenging. And I'm not able to generate as much peak inspiratory flow. Now I'm down into that 60 range. Now, theoretically, the device that is this maximum flow, the HandiHaler, that supposedly actually takes some of that into account, and you should only need about 30 liters per minute. That's what the advertising will tell you. I am not 100% convinced, and I'm also not 100% convinced that the HandiHaler is a particularly great device anyway. It's got a lot of other issues. I'm not a fan of single-dose dry powders. I'm not a fan of a lot of that stuff. But the point remains that these devices have different resistances, and we as clinicians need to be evaluating that. Your role as a patient, as a caregiver, whoever, if you're whatever non-clinical role you may have, is to ask your provider, how do you know that I am getting the medication out of my device? And if they tell you that they don't know how to know, then now you can educate them on the in-check dial. This is relatively inexpensive. Again, not saying that as a promotional tool or anything like that, but as a patient advocate, there's really no reason for offices to not have this. It's $75, $80, and generally the process of inhaler technique assessment, all that stuff, there's actually a reimbursement code for it. So it will pay for itself very quickly. The problem is a lot of clinicians don't know about it. So we'll be relying on you in the advocacy community to help get that word out there. So we'll pause for a second here and see if we have any other questions or anything like that. So Cindy mentions powder doesn't work as well for her, is now using the Spiriva Respimat, which is entirely appropriate. And I think I just forgot to grab one of those. Flat out forgot when I was grabbing stuff out of my office before. I was all excited about the powder and all excited about some of the other stuff. But for those of you who may not know, we'll see if I can pull that poster up again real quick, and we'll try and highlight the aforementioned Respimat. So we've got that guy right here. This is a device made by a company called Boehringer Ingelheim. There we go. Looks like a little torpedo. Basically what that does is it's very similar to our traditional meter dose inhalers, except instead of using a chemical propellant, it uses a spring and actually forces liquid through some very laser drilled nozzles and creates a slow moving mist. Does tend to work fairly well, again, in the right person. The trade-off on the Respimat is that it can be a little bit difficult to twist. When you turn it, you've got to turn it instead of pressing it in order to actually tension the spring. That can be a little bit tricky. And it can be, you still need to have some degree of coordination between the clicking, the activation or actuation, what we call it, and your inhalation. So again, the right tool for the right person. Cindy is a case where the Respimat seems to work a little bit better for her. And that is not uncommon. Again, we've got people who can't do the coordination, can generate the flow. Powders are fantastic for those folks. It's great. This is the kind of thing, even if you have dexterity issues, if you've got arthritis, this is fairly easy to open, even flat. You don't have to do the coordination. You don't have to do any of that stuff. But if you can't generate the flow, then you're not getting the tool. And the problem is, because we're not using these tools like the InCheck, let's say from a clinical side of things, you are a primary care provider and you have your newly diagnosed person, you're sending them out into the world with their brand new powder inhaler, and you're telling them to use it once a day, every day, no matter what. It's controller device, controller inhaler, that's what you're going to do. They come back to see you in 3 months, 6 months, whatever it is, and they tell you, well, doc, well, NP, well, PA, that medication you gave me didn't work. And have you been taking it every day? Yes, I have. Absolutely. Every day, every morning, just like you told me. So as a clinician, we think one of a couple of things. First of all, well, this person is full of garbage, full of baloney. They're not telling me the truth. They haven't taken their meds, but they don't want to look bad. So maybe that. Or, oh no, maybe this person is sicker than I thought, and now they need more medication. So we're going to give them another powder, because that's what insurance says we can give them, and we don't know any better. We can assume, well, if you've been taking it every day, you must be able to take it. Those are probably the two biggest things. Maybe you're using it improperly some other way we haven't figured out yet. But what actually is going on is, yes, the person really is taking it every day. No, they're not. They are precisely as sick, as severe as you thought they were, but they're just not able to get their medication. So they are actually not adherent to the plan. You're not actually getting the medicine, but you don't know it. A lot of these don't have much flavor, and they're not supposed to, because the more that goes on your tongue, the less it's going into your lungs. So it is very, very difficult to tell whether there's stuff going down into your lungs or not. So you don't know. We don't know, because we're not measuring and we're not watching you take the med. Nobody knows whether the stuff's going in or out or not. So that's why it's critically important that we're doing these peak flows and peak inspiratory flows and stuff like that. Now, excuse me. The other main, I get a little bit excited about that, and I see James is James. How you doing? James, another navigator type fella, who joins us every couple of weeks. Appreciate you stopping by. Would like to let patients know it's also okay to talk to your doctor about nebulized medications. We find many who use their inhalers but not correctly time after time. It is okay to use nebulized medications. Yes, absolutely. That's a great point. A lot of times, actually I have this conversation several times a week. A lot of times people will say, why don't I have a nebulizer? That's the powerful stuff. That's the good stuff. That's what they give me when I go to the ER. That's all that, everything that's going on. Or am I sick enough to need a nebulizer? We as clinicians tend to look at nebulizers being, in the outpatient world, almost like a last resort, because they are a little bit less, these have trade-offs too. They are a little bit less portable. Modern devices are portable, but they don't necessarily have a battery. So they're not necessarily something you can take on the go and just use whenever you want to. There are those that have a battery, not usually covered by Medicare because it's not medically necessary. Sometimes they have a car adapter. Sometimes you can get some portability options to it, but there's often this idea of, well, we're going to be taking away mobility if we put somebody in a nebulizer. So we're going to wait until we absolutely have to. We also are going to wait until they're severe enough to need it, because they should be able to use an MDI. They take longer, so taking up more time. we have this notion that we need to wait until somebody has exhausted all other options to go onto the nebulizer. Unfortunately, so do a lot of our payers out there. I run into that a lot too. A lot of our Medicare, Medicare Advantage, Medicare Part D, private payers, all these groups, Medicaid, don't really look at a lot of the science behind these things when they're designing their formularies. And again, that's a whole other issue that we can talk about, and I go into a little bit on my other podcast. But we're working on changing that. Again, that's where we need input from the community, from the users, to go to your payers and say, hey, I need this medication so that my provider's office doesn't have to do 8 pages of paperwork in order to get me the thing. But getting back to the nebulizers a little bit, James is absolutely right when he says that if you aren't able to use your nebulizer, again, we're looking at, can you coordinate? That's your meter dose inhaler. If you are not able to coordinate, can you generate that inspiratory flow? That's your dry powder inhaler. And if you can't do either, or if you have bad arthritis, or if you have dexterity issues, maybe you have had some cognitive problems, or people who have had strokes, things like that. You can't always use your hands real well. Nebulizers are a fantastic option even at relatively mild stages of COPD or other lung conditions. So if you feel at any time that you're not getting what you need out of your medications, please do not hesitate to talk about other modalities, the fancy medical word for other delivery techniques, delivery devices. We now have at least one medication in every class available in, I believe, every form. We've got a nebulizer, bronchodilators, both kinds now, nebulized corticosteroids. We've got MDI corticosteroids, I'm talking too fast now, bronchodilators. We got all the stuff. So it's up to the clinician and the person together to work together to figure out what's best going to fit their needs. Now, arguably more complicated than even the DPIs are, as I said, our old friends, the MDI. Even though we've had this technology for 50 years, we still don't use it properly. And that's why we have this device. Now, Vitalograph they do not pay me per se, but they have been kind enough to give me a few demo devices and things like that. So full context, I don't know if that gives me bias or whatever. They started doing that after I started talking about how good how important this product was to my practice, which again, I firmly believe. This is a little bit more expensive than the in-check dial, so you're going to see a lot of practices kind of balk at this, but it is, again, a very useful tool for us to teach you how to use your device correctly. And the way this thing works is most of the time, I'll say, show me how you use your inhaler, and I'll put them on the device. But if anybody ever watched that, the oldish television show House, there's a scene where a woman, he asks, show me how you use your inhaler. And she says, yeah, I'm no dummy. I know how to use it. And she does. That's not going to do a lot of good. Also, we see a lot of times in the media, we see people using their inhalers like this. We're taking that super fast breath. We're doing all that stuff, immediately, and of course, we're getting instant relief and all that stuff. But the problem is, if you think about how your neck works, as soon as everything goes in, it's got to turn and get down into your lungs, right? So if you're in a car that's going too fast around a curve, then you're probably not going to make it around the curve. You're going to hit the guardrail and all that stuff. And same thing happens with the inhaler. You've got molecules that are coming out super fast. We don't need to speed them up. We just need to give them a path to get them down where they need to go. So the first way we do that is with this kind of device. This is called a valved holding chamber or a spacer, or that sort of thing. Basically, the way this thing works is you are able to put this on one side, put your mouth on the other side, like so, and you're able to puff and then breathe in without as much coordination and without worrying about that super fast flow that comes out of there. This is a great tool. Up until very recently, though, we again had a lot of payers balking at giving that because this is technically not medically necessary, even though it is the best practice. And most of our studies out there tell us that, yeah, you should be using one of these with pretty much every utilization. We also see that while this is very portable, this is less so. And so, especially in our kiddos who maybe want to keep this in a pocket while they're at school or something like that, if they're able to, this isn't going in too many pockets out there. So it's also very important to be able to do the technique without the valve holding chamber if at all possible. And that's where our friend, the aerosol inhalation monitor, comes into play. This is really nice. It's got a bunch of lights that can light up and tell us what's going on. And the way this thing works is we actually have what's called a simulator, where I have a placebo inhaler canister. Basically just has some water and the propellant in it that goes in our simulator, which hooks into the tube here. And there's a pressure sensor in here that can detect when I puff the thing and when I breathe in and how long I breathe in and how fast I breathe in. And that way I get a very good indication of how good my technique is. So I'll show you. And then when I'm done with the technique, it starts a timer, because you should also be holding your breath at the end of your inhalation process. So I'll give you an example of how about 90% of the people who come into my office do their inhalers, because we as clinicians haven't bothered to teach them very well. And hopefully it was loud enough for you to hear. We got a, and we can see on our nice little graph here, we see red lights for coordination. We see a red light for flow, a red light for inspiratory time, and a red light for breath hold. All of these things are problematic, and we see over here on the diagram that most of the medication is probably getting to the back of the throat, and that's about it. So then that's when I do my little teaching, and I say, okay, so you need to blow everything out. Put it in your mouth, make sure it's past your teeth and not aimed at your tongue and all that stuff, and make it nice, slow, deep breath like you're about to sigh or yawn. You just, that kind of thing. And then make sure you're holding your breath for 5 to 10 seconds or as long as comfortable. The book will tell us that the longer the better. Should be at least 5 seconds. That's what the timer set for on here. And we should see some improvement. So now I will play the role of, now I'm doing a little bit better with my technique. I didn't do my breath hold, so now we're seeing a little bit of improvement. Here we see good inspiratory flow. I'm not blowing the doors off the barn, but I didn't do it long enough, and I had bad coordination. So I'm still, now we see that not only is it not even getting to the back of my throat now, it might not even be leaving my mouth. So then I do a little bit more coaching, a little bit more teaching, and we'll try it again. And now we had a little happier tone, if you can hear that. And now we've got all green lights and everything's getting down into the bottom of the lung where it's supposed to go. So that's where you can see a difference. We've gone from not being able to get any medication in and not being able to do any good whatsoever. And then when the person comes back in 3 months, 6 months, not feeling any better, another several months of lung function wasted. Or concern, are you sicker than you thought? Are you not? Are you one of those people that doesn't tell the truth about their treatments and their adherence and all that stuff? All those issues. Now we can be a little bit, or do you actually need a different medication? Because that's something we haven't even really talked about, is yes, we have all these different molecules out there. Everybody responds a little bit differently. We have drug classes because some people like molecule A, some people respond better to molecule B, some people respond better to molecule C. We don't always know why, but we need to have these different options out there so that we can tailor treatment to the person. the device, the molecule, all of the class, all of these things need to work together so that you get the therapy that is going to treat your symptoms the best. So let's scroll back for just a second here. All right, so we've gone back a little bit. Phil mentions a COPD sufferer, but work as a bus driver in the UK, handling money and in close confinement of tourists. Various passengers all day. Big concern with the coronavirus. Absolutely. Again, this is where hand washing comes into play. This film might be the class that I might say learn how to use a mask properly, because that is very high risk. Having immunocompromised through COPD, having a lot of people where you don't know where they came from, you don't know who they were exposed to, handling all that stuff. Definitely going to be doing a lot of hand washing, definitely going to be doing a lot of sanitation, definitely not touching your face, doing a lot of those things. Gabby, thanks for joining us from Idaho. Gabby is a fantastic resource. Very excited to have her on the program today. You want to talk about smoking cessation? Gabby is the person to talk to. She is fantastic at this. The in-check device, again, another vote for being relatively cheap. Yes, every office absolutely should have one. Again, patient preference, important. That's another thing we didn't really touch on. Back in the early 2010s, there was a paper that was out, an actual clinical practice guidelines, evidence-based expert panel from the American College of Chest Physicians, the American College of lots of A's and immunology, asthma, allergy, something else, and immunology. Actually put together guidelines, patient preference, because if you don't like the thing, you're not going to do the thing. I mean, we talk about that, and I see Brian checking in too. Also, hello. Brian's done, he is an RT who also deals with chronic lung disease himself on a daily basis, and he can testify to the importance of exercise. You don't do an exercise if you don't like the exercise. You don't do a task if you don't like the if you don't like the taste of your medication, if you don't like how it makes you feel within the first 5 minutes, things like that, you're not going to take it. So absolutely, patient preference, huge. You know, you can have the right tool, you can know how to use it, when to use it, all that stuff, but if you're not using it because you don't like it, it's still not going to do any good. And I'll see what I can do about getting you one of these AIM devices. You know, again, they're a fantastic tool. If nothing else, we'll talk at down in Texas. We're going to be at a conference together this summer. I'll pack it in my carry-on. I'll show it to you a little bit more when we get down there. But see what I can do to spread the word for you, and get that out there for you. Let's see. Let me check a couple other spots here too. James, scrolling back a little bit here, handheld mini nebulizer, $50 to $79. That's fantastic. Great tool for relatively inexpensive nebulizers. Saw a person spray it onto a plastic spoon and then lick it. What can you say? I actually had a conversation with some folks at AARC. We have a guide, the guide to nebulize aerosol medications, because it talks about nebulizers, MDIs, all that stuff. And we're being a little bit picky because we're getting ready to release a new tool to help with COPD discharge planning. And part of the references that come into that is inhaler technique. And I have seen, there's one device that we haven't really talked to. It's a meter dose inhaler that is automated. It has a flow sensor in it also, so that you don't have to puff it. But because it's not a powder, because it's a meter dose inhaler, if you're not getting the training, I have seen people actually rip off this cover part to get at the puffer, and then the thing doesn't work, and they're like, I don't understand why they gave it to me, it was broken. I haven't seen anybody lick a spoon before, but you know, we talked before about how humans are infinitely adaptable. Humans are also infinitely creative when it comes to doing stuff. So if there is a way to do it unusually, we will find a way. So training is important. Ongoing training is also very important. We know that in my own clinical experience, I had a person who we spent about 6 months optimizing technique, getting everything planned, and monthly visits, 6 monthly visits. We finally got technique was perfect, consistent, knew which medication was 2 puffs once a day, 1 puff twice a day, had all that stuff locked down, good to go. I felt like mama bird, time to go fly. You get out of the nest now and go fly. You come back in 6 months because you're stable, you're well handled, all that stuff. 6 months later, symptoms were flaring up again, all that stuff. And I was like, well, what happened? Show me your inhaler technique. Completely forgotten everything that we had talked about inhaler technique. Because again, this is human nature. You take shortcuts, you get complacent, you get silly with stuff. We have to, in the clinical side, we have to continue to do these trainings over and over again at clinical encounters so that the people we're caring for are able to care for themselves. And James, I will also hit you up with the information about the aerosol inhalation monitor and see what we can connect with there. Let's see. So we'll get to our bottom line stuff, our kind of wrap up that we like to do. There are, of course, a huge number of factors that affect how you're using your nebulizer, how you're using your inhalers, your dry powder inhaler, your slow mist inhaler, your meter dose inhaler. Lots of factors. You need to make sure that your clinician is observing each one of those. Your preferences, your cost factor, all of these things, that anything that we can have control over, we need to make sure that we are exerting some control over. The proper use of these things is critical. The analogy that I often use is a screwdriver, trying to insert a screw with a hammer. You may end up getting some of the job done. Just like if you're not using proper technique, you may get some of the medication in there, but it's not going to go well. Nobody's going to enjoy it, and you may end up having extra issues down the road. Don't do it. Use the right tool for the right job. Clinicians, we need to be checking this early. We need to be checking it often. We need to make sure that the people we care for have the tools and the knowledge to use the tools. And then finally, the right tool for the right job. Again, use the proper thing that is going to get the best results. It's going to be individualized. It's going to take a while to figure out what's going to be the best results. Usually it takes a solid 3 months or a couple of different med trials, a couple of trial and fails, all that kind of stuff to figure out what the best regimen is. It's unfortunate because while we're waiting for that stuff to work, a lot of times you give somebody, this is an extreme example, but you give somebody morphine, it works right away. You give somebody nebulized albuterol if they're in bronchospasm, works right away. A lot of these things don't work right away. It takes time. It takes a week, 2 weeks to get full function area to where you're going to be. And so it takes some time to figure out what's going to happen. We got to wait on paperwork, then we got to wait for the pharmacy, and then 2 weeks of run-in time. And then we can see, are you responding to this therapy? No? Okay, let's move on to another one. It takes time, and we've got to be checking back with these things to make sure that everything is going appropriately. So with that said, now we've got some question and answer time. We'll scroll back through and see if we can find. All right, James found the aerosol inhalation monitor. Excellent. So let's see what else we got here. We've got some time left. We did run a little bit long between our old friend coronavirus, novel coronavirus, and getting a little bit passionate with the inhaler technique here. But we do definitely have some time for questions if you want to get those in here. Val checking in, I believe also from across the pond. Carla, hello. Nice to meet you here. Valerie says, I am on Trimbo. I use it with a spacer. I find it's a good inhaler, 3-in-1. So, okay. Now we run into one of the issues that we see sometimes is these medications often have different names depending on what locality you're on. So Trimbo is one that I am not familiar with. So let's get my technology back in order here. And we are going to look up Trimbo because I am curious as to what that is. Trimbo. Being a 3-in-1, I'm going to assume it's both bronchodilators plus an inhaled corticosteroid. Whoops. Why is... No, I don't want to go to... Come on, technology. Trimbo inhaler. Oh, Trimbo. Okay, so Trimbo does indeed have glycopyrronium, which is a component of Bevespi and a couple other meds. We can bring the poster back up, but that is what we call an that's an anticholinergic bronchodilator, much like Spiriva. We also have beclomethasone, which is an inhaled corticosteroid, and formoterol, which is a fantastic long-acting beta agonist, kind of a long-acting form of albuterol. We like that because, like albuterol, has a relatively fast onset. We're talking about 5 minutes. In some places, in certain protocols, some formoterol inhalers can be used actually as a reliever inhaler. So Trimbo is does seem to be a pretty good option for those folks who, again, may be able to coordinate. Valerie mentions that she's using a spacer. Again, spacer, another word for one of these holding chambers. Sometimes a little smaller, less fancy, all that kind of stuff. But that may work. Now, in the U.S., there is currently a triple therapy inhaler called Trelegy, but it's a dry powder. So again, great tool in those who can generate the correct flow, but not necessarily the right tool for everybody else. We're more often left with doing 2 in 1 inhaler and then another inhaler. And where it gets real complicated is where we have 2 in a powder inhaler and 1 in a meter dose inhaler, because we're looking at different inhalation techniques, one where you have to coordinate, one where you don't. That's where it gets real messy real fast. So Val, thanks for giving us some input on Trimbo. Learned something new. That's a new medication. I suspect we're going to be seeing a lot more of these triples coming out into the market here in the U.S. before too long. I know in Japan there was a triple that was just approved not long ago. And I think we'll be seeing that a lot more again as time goes on and we get through the approval processes around here. So a few more minutes to go. Let's see, not seeing much coming across in the COPD Navigator group. Again, if you are on Facebook, if you're watching this on Facebook, come join us in our COPD Navigator group. You can find that with a fairly straightforward search. If you are catching this somewhere else or catching a recording of this on YouTube, we also do comments. We also do the live show on YouTube as well. We got some notifications here. Let's see, is anything coming in? Oh, some older stuff, but that's all right. Let's see, we got a thumbs up, so that's cool. If you choose not to follow us on Facebook, you are welcome to follow us on YouTube. I don't even generally have to sign in there, so that can be a plus. Also, we have our Twitter at COPD Navigator. We've got the audio component to this does go through podcasts, so you can catch us on Spotify, Apple Podcasts, Google Podcasts, a lot of those kind of places. Catch that. And then we are also doing, as I mentioned earlier, the Potato Cast, which is a little bit more general healthcare topics, not as specific to COPD, but certainly relevant. If you just can't get enough of my dulcet tones, you are welcome to check that out. Not seeing a lot of other questions and comments coming through here, so we are going to start wrapping things up. Let's check back in over here. Okay, not seeing anything there. We're going to check. So we've got, we will do next regular podcast episode. Next Potato Cast will come out in next week. Next up for COPD Navigator is going to be in 2 weeks. Again, we're going to do Monday. We're going to do Wednesday at 4:30. We've got, let's see, what's our next topic? I don't know that did I throw one on the, I'm running a little bit behind, I believe, on the old Facebook events. Let me see if I can pull up the page here. I believe we're going to be talking about inflammation. Yes, Wednesday, March 25th, we're going to be talking all about inflammation. We're going to be talking about the role of inflammation in COPD and the changing role of inflammation, and how we need to start evaluating for it and what we can do to treat some of that. Then we've got some other topics coming up, but if there is something you want to see, tweet at me, drop me a line in the comments, join our group and let me know. We're always happy to talk about all kinds of stuff here on COPD Navigator. We've got a fantastic group full of people, all kinds of different experiences. We've got clinicians, we've got caregivers, we've got all kinds of folks who are fortunately very open to sharing a lot of their experiences and helping people also along the path here as we wander through life together. So we'll check one more place real quick. I do hope that everybody is getting through a lot of the scares out here. And again, I don't want to minimize risks or anything like that. We do all need to be very careful out there because we don't know. There's still a lot of unknowns, frankly, when it comes to coronavirus and when it comes to a lot of other stuff. So, but a good healthy dose of common sense and usual infection control techniques out there, washing your hands, avoiding touching your face as much as possible, isolating when necessary, avoiding people when necessary, all those kind of things. That's our best strategy right now. So with that said, still not seeing any more comments, so we'll go ahead and we did get one through from Dave Swift. Big issue is inspiratory flow is not checked. Some people cannot use the device as prescribed. Yes, sir, very much. We talked at length. We talked about our old friend, the in-check dial, checking out these inspiratory flows. You can do it with basic spirometry, but the advantage to this is it's usually a lot cheaper, usually a lot easier, and this is adjustable to get those different resistances on the market. Now, you will also see some data out there that tells you that clinical outcomes have not been necessarily studied with suboptimal peak inspiratory flow, which is true, but it also stands to reason that if you're not getting your med, you're not going to have as good an outcome. We can't make that claim because we haven't studied it yet. So, yeah, Dave's absolutely right. Dave checking in from Canada. It's a huge issue, and it's something that we in the clinical side of things need to address far more aggressively than we have. So, with that said, we are going to time to move away from nebs due to aerosol risks. Now, banned nebulizer except for drugs, not available as MDI. It's tricky. We've got, and now we're hearing the converse to what James was talking about before. Some people really vote for aerosol or nebulizers, and some people are a little bit more against it. I, again, stick with, I know I threw a Buddhism reference out there before, but I'm a firm believer in the middle way, somewhere in between, the right tool for the right patient. With some of the aerosol concerns that are out there right now, particularly inpatient, yeah, I can definitely see where that might be a concern. The CDC has issued some guidance for respiratory therapists to minimize our aerosol generating procedures in the inpatient setting with the risks of exposure. In the outpatient world, I would maintain that things are a little bit different. And if your aerosol, your nebulizer is going to be the best tool, then absolutely. If it's an MDI, absolutely. If it's a dry powder, absolutely. If it's a slow mist inhaler, absolutely. It's tricky walking that path. This is another one of those times where we've got a balancing act out there, so we've got to be careful. Right tool for the right patient. That's where I plant my flag. I might be wrong. I've been known to be wrong in the past, but that's the best advice I can give. So, I do absolutely appreciate everybody else checking in today, everybody giving, sharing their wisdom, their perspectives. The way we figure these things out is all by talking to each other and pushing forward and finding the best solution for the most people. So appreciate healthy debate on any topic. And like I said, I could well be wrong. I don't have all the answers, and I don't claim to. I encourage everybody to get their answers from multiple reliable sources so that you can find the best solution for your own needs, whether they're practice needs, whether they're clinical needs, therapy needs, whatever they are. So with that, we're going to shut things down for this session. We'll see you back in a couple of weeks for inflammation issues. We'll see you in the podcast world for the audio version of this, plus the Potato Cast. Make sure that you're sharing this stuff with whoever you think can benefit from it. Always appreciate extra audience members coming in, both to support the movement here and to share opinions and all that stuff. So the more the merrier. And hopefully people can also learn from some of this stuff maybe that you wouldn't get in a real quick office visit. So as you go out and about, take care of yourselves, take care of each other. Appreciate everybody stopping by and sharing some of your Wednesday with us here. And we'll see you in a couple weeks on COPD Navigator Breathe TV. Take care, everybody.